metamorphopsia, and the program has been prepared by Rupak Kanti Viswas. And I hand you over to Rupak for further proceedings.
Thank you, sir. Thank you for giving us this opportunity. And it's an excellent topic, and this is very much needed for the general ophthalmologist as well, which we do see on a day-to-day basis. And for this today's program, we have our chairperson, Dr. Hemant Murthy sir and Dr. Shabit Chawla sir. And both of them, Dr. Hemant Murthy from Retina Institute of Karnataka and Dr. Shabit Chawla, Prakash Netra Kendra from Lucknow. And both of them are very senior familiar faces in retina fraternity, and both are having an experience of more than 40 decades of retina services. We have our expert panel here. Dr. Manavi is Chief of Retina Service at Arvind Eye Hospital, Pondicherry. We have Dr. Manisha Agarwal, Chief of Retina Service of Stop Charity Eye Hospital at New Delhi. Dr. Mohit Dogra from PGI Chandigarh. Dr. Piyush is unwell, so he may join us after some time. And Dr. Rajiv Reddy is Vice Chair of LV Prasad Eye Institute, Hyderabad. Dr. Saurabh Sinha is Executive Director and one of the senior retina specialists from Kolkata at Netralayam, and Dr. Vinod Agarwal from RP Center, AIMS, New Delhi. And we have our star of young presenters, who is Dr. Abhishek Kedia, and he's director of Lakshmi Eye Institute, Patna, and did fellowship from Arvind Eye Hospital, Coimbatore, and Sydney Eye Hospital. We have Dr. Bhaskar Ghosh, who did fellowship with at Netralayam Eye Hospital, and he is doing Chief of the Retina Services at Renuka and Lokeshananda Eye Hospital. We have Dr. Harshit Vaidya from Vaidya Eye Hospital, Mumbai. Dr. Janani Srinivasan is consultant at Retina Services at Shankar Netralaya, Chennai. You have Shubham Sinaroy, Shankar Deva Netralaya, Guwahati, and Dr. Subhashini, fellow at Arvind Eye Hospital, Pondicherry. So with this, sir, we will just move on to our presenter. Dr. Abhishek is here. So we'll start with Dr. Abhishek first.
Yes, sir. Just sharing my presentation. Is my screen visible?
Yes, Abhishek.
Yes.
Doctor, you can just make it in slideshow mode, please. That's
Yeah.
Right.
Okay. Good evening, everyone. So this is an eye that fooled us, and it's a case of posterior scleritis masquerading as central serous retinopathy mimic. So I am Abhishek Kedia, and I work at Lakshmi Netralaya, Patna and Ara. So this 42-year-old gentleman presented to us with diminution of vision and periocular pain of 1 week duration, and he had complaints in his right eye. He was referred to us. Actually, he was not referred to us. He was diagnosed as CACR in at the center in one of the cities of Bihar, and he came for second opinion to us. So the primary diagnosis made at the primary center was central serous chororetinopathy, and he was put on conservative management, and non-steroidal anti-inflammatory drops were given. In 1 week, he had no improvement, and there was worsening of the pain. So what the referring symptoms was, the ocular pain was not attributed to, it was attributed to anxiety. B scan was not performed, EDI-OCT was not done, and systemic workup was not initiated, and the pain was worsening. These are the anterior segment photograph, which is not it just shows some circumciliary congestion, nothing other than that, which is remarkable. And this is the fundus photograph in which you can see in the right eye. So this patient had disc edema along with a few choroidal folds and a mound of SRF. So when I saw this patient, because in CSCR we just see the subretinal fluid, not the choroidal folds or the disc edema. So I had suspicion that this is not CSCR, this is something else. So I asked him to undergo OCT. He already had OCT, but he was not willing to undergo a second OCT because he just got it done 1 week back. But I pursued him, and then then he underwent OCT. You can see in the OCT on your left hand side, there is this deposition of SRF along with another mound of fluid, which is probably the separation in the photoreceptor layers, and the HRF, the hyperreflective foci in the middle layers of the retina. Along with this, in this photograph, it is not very evident. I'll show you in subsequent slides. There was thickening of the choroid as well as the sclera, which is not very evident here. Whereas on the left eye, you can see it's pretty normal foveal contour. This is just the higher resolution magnification. And as I was saying, so you can see here the thickening of the choroid as well as the sclera on your right hand side, and not very evident on the left hand side. So this is where the confusion begins. So CSCR, you see there is a mound of SRF which is very evident. So there is no not much of choroidal thickening or scleral thickening. Whereas in this, when you see the photograph on your right, there is choroidal thickening and the scleral thickening, not very evident, but it is there, which is there on the subsequent line scans. But on those line scans, the SRF mound was not mentioned, so I had to take these scans. So in CSCR, there is a very shallow neurocentered detachment, normal choroidal thickness, or they may be pachychoroid, and no scleral wall thickening. This is the pathognomic of posterior scleritis. So here you see classic T sign, that is the presence of subtenos fluid. Sorry. Just a minute, the presentation has gone up. I'm just continuing.
It's visible on our screen.
Yeah, please go ahead. Is it a video? Dr. Abhishek, is it a video or?
Can you see my slides?
Yes, it is there, but it's not moving.
I think you can sum it up now. It's
visible now?
Yes, it is visible, but it is stuck there.
No, I'll move it. So this is the ultrasound which is showing classical T sign, so which is pathognomic of posterior scleritis, and the B scan was not done at the referring center. So that is the other. That's why probably they were clueless, and if they would have done this, then they would have cleansed the diagnosis.
Okay, please describe your next management because the slides are not moving, so we're just losing time. So can you just describe your next line of management, what it was?
I'll just say again. Okay, so this, am I visible and audible?
Yes, it is moving now. Go ahead.
So these are the investigations. So most of them were within normal limits, so we could not conclude any etiology for it, but most probably it was idiopathic, and the patient was started on treatment oral prednisolone 1 milligram per kg per day, along with indomethacin BD 75 milligram SR. And we observed a significant resolution at 1 week. So you can see here, we did multimodal imaging for him. So EDI OCT was done, FFA was done. We did not so much of leakage other than this window defect. Otherwise, this was normal. The B scan was done, which showed the classical T sign. So the etiology by idiopathic. And you can see on the FFA, it is not showing any thing other than this window defect. Otherwise, there is no leak, ink blot, or a smokestack as seen in CSCR. Actually, this FFA was done in the second visit, so we are not seeing any disc leakage or any pooling here, because by the time the patient visited second time after 1 week, there was a lot of resolution of the SRF and everything. So you can see on the photographs, the disc edema has gone, the choroidal folds have decreased, and the macular fan has appeared here, which is a little bit atypical, like less common presentation of posterior scleritis when it is resolving. This is the montage of the FFA. Doesn't show much any finding other than the window defect. And this is the montage photograph of the second visit, which is showing the findings as described. And these are the comparative photographs. That, like the first one on your left is the patient presented on 2nd of May to us, and the one in the middle is the 9th of May photograph, and the third photograph on the extreme left is on 30th May. So you can see there is very demarcated, very good resolution, but only thing is the macular fan is apparent, that's also disappearing. And these are the serial photographs of the OCTs. So the resolution is of the SRF as well as IRF. HRF is very well. And on the last visit, like I have just seen him on 30th of May, the SRF has resolved and the hyperreflect foci are also going down. So the red flag which should have stopped us thinking of CSCR, that there was ocular pain and CSCR is painless. There was no leakage on FFA. The choroidal folds are there at posterior pole. So we should have thought that usually the scleral thickening is not there in CSCR. There was no improvement on observation, and usually the pain was increasing. So that should have that should have led us to think that this is not CSCR. So the presented visual acuity at referring when the patient was actually came for second opinion to us was counting as 3 meters. Treatment started and oral steroids were started in 1 week, and we got very good response in 2 weeks. And the presenting visual acuity at in 1 month is 624. The final visual acuity is yet to come because we are still expecting, we are still on the oral steroids, and is yet to come in another 15 days. So in CSCR, the ocular pain is absent, which is usually seen in young males. The SRF is present on OCT. Scleral thickening is absent in CSCR, where it is present on posterior scleritis and visible on EDI OCT. So it's always good to order EDI OCT. T sign is very pathognomic of posterior scleritis. Usually we see ink blot or smokestack pattern of leakage in CSCR and diffuse or non-focal in posterior scleritis. Choroidal folds are absent in CSCR, and it is usually present in posterior scleritis. And the systemic association, like stress or steroids, may be associated with CSCR, whereas most commonly it is autoimmune or TB or idiopathic in posterior scleritis. And the investigations, as already discussed, so posterior scleritis will need multimodal imaging, and the CSCR just needs OCT, and if not, resolving FFA. So this is the take-home message. Any pain, it is a scleritis unless until proven otherwise. B scan is mandatory for atypical SRF. Ordered EDI OCT, not standard OCT. FFA without a classic click. It should not be attributed to CSCR, and we should always rule out TB before starting steroids in India. And if it's not improving on observation, always re-diagnose and re-evaluate your patient. So this I did not fool us because we listened to its pain. In ophthalmology, pain is not a complaint, it's a diagnosis waiting to be made. Thank you.
That's a fantastic presentation, Dr. Abhishek. We'll move on to you can have your presentation sharing as well, so that if needed anything, we can refer there. Dr. Manisha, we'll go to Dr. Manisha. Dr. Manisha, how to differentiate when patient present with uniocular such kind of decreased vision with metamorphopsia, and you see a present of SRF. So what should be the examination points they should look for, they should not miss, so that you can differentiate between these two?
So thank you, Dr. Rupak. I think, Abhishek, you've made an excellent presentation. And I think these are two entities which are very commonly confused. And you beautifully described in your presentation that the clinching symptom was the periocular pain, which cannot be missed. And that is suggestive of some kind of an inflammation going on in the eye. Other than the pain, the other things which we can be a little more observant on clinical examination is the hyperemic disc and any other sign of inflammation in the eye. Like in your patient, when I saw the color fundus photograph, and if you see, the disc was quite hyperemic.
Yes.
So that is another thing which goes in favor of an inflammation again. And if you see the OCT carefully, you have described the various other features like SRF, the choroidal thickening, but you also see there is a bump. There is a huge choroidal bump on the OCT, which actually goes in favor of a posterior nodular scleritis. And that is another thing which we have to keep in mind. Other things, as you described, the B scan, which was showing the T sign, which was very classical again of scleritis. So these are the various things, like right from symptom to the clinical examination to utilizing the various diagnostic modalities. I think somebody cannot really miss. The only thing is that as far as the FFA that you showed was not very typical of a scleritis, because it usually shows those multiple pinpoint leaks. But as you mentioned that the FFA was done in the second week when the patient was already on a high dose of steroids, so probably the leaks had already subsided. And that is why you did not see the typical presentation on an FFA. But otherwise, you have beautifully described all the differentiating features between the two entities.
Correct.
Can
That
I
is
ask
absolutely.
Dr. Manisha's opinion on this case? One question. May I?
Yes. Please go ahead, sir. Please.
Manisha, you were talking about the pinpoint leaks. The pinpoint leaks, which are there many times, look very confusing, like VKH also, when you see them at the posterior pole in FFA, if done before steroids are started. What do you feel about that?
Sir, absolutely right. But the OCT is going to be very different. So you are going to have the septae. The fluid is going to be having those classical septae, which you find in VKH, which are not going to be found in scleritis. So what you mentioned that on FFA, the pinpoint leaks are very similar. The disc leakage is very similar in both the entities. But I think a B scan showing a T sign will go more in favor of a scleritis. And those typical septae, I will err on the side of a VKH, sir.
And may I ask you another question, Manisha ma'am? So is that the only difference, or the VKH patients will have the other additional signs like tinnitus and the alopecia and all? Then only we can attribute it to VKH, or it's just the OCT septae finding we can tell that
So
it's
Abhishek, what we usually see in our patient is more of the Harada's disease rather than the full-blown VKH.
yeah.
So they usually don't present with the systemic features, and it is mostly confined to the ocular signs. So the only thing sometimes you may find is a neck pain or a vertigo kind of a thing, but that also is not always present. So I think we'll have to, mostly the patients who present are mostly the ocular symptoms and the ocular signs that, and the diagnostics like OCT is something that we have to make our diagnosis on. Maybe Dr. Mohit can add something more if he wants to.
Yes,
Adding
Dr.
anything, ma'am?
Manu.
Just actually adding, kind of two different caveats to this. So we talked about the characteristic ultrasound, which is the T sign, and absolutely. But there is one exception to that. If the patient comes when the patient is being partly treated, Like, had you done the ultrasound, Dr. Abhishek, at the same time when you had done the FFA, right? A
No.
couple of days after starting treatment, you would not have seen the T sign. What you will actually see, and which is the first sign of early posterior scleritis or a sign of a partly treated posterior scleritis, if it comes to you, is hyperechogenicity of the sclera without the T sign. Generally, we don't tend to see it because by the time patients come to us, they're in that full-blown picture. The idea is, and this is textbook, because the inflammation is in the sclera. So you will just get a hyperechogenicity of the sclera and not that in very early posterior scleritis or early treated in which the fluid's gone. Two, I think we talked about posterior, scleritis isolated. I think a variety which is thankfully, uncommon, but one needs to know is the giant nodular posterior scleritis. And why one must know that is because people have in the past, before this entity was recognized and documented, enucleated eyes, thinking that it's a choroidal mass or a amelanotic choroidal, melanoma. It looks and walks and talks like a choroidal mass, but it's not. Generally, giant nodular posterior scleritis will not have pain. It will not have congestion. So it will have most things which are not fitting into your classic posterior scleritis. And in a lot of cases, it might not be associated with what you might find systemically as other things. And one last thing, once I think we have labeled a patient as posterior scleritis, and we have ruled out infections which are generally a minority. They are generally autoimmune, idiopathic, and then infections at the very least. I think for the most part, recurrence is the norm, and a very low threshold for immunosuppressive therapy at the get-go, like with VKH disease, should be kept in mind. Just 3 points in addition to what was talked about.
Thank you.
I think Dr. Mohit is absolutely described it, but the main focus is for the general ophthalmologist, where they have actually missed this case to diagnose because probably they have missed those initial symptoms. Number one is pain. Number two is disc hyperemia, and the OCT also is not typical of SRF. CSR SRF, where the intraretinal component is not there. Here, the intraretinal component of the inflammatory part, and there are few deposits which is also there in the initial OCT. That gives you the classic triad of thinking that this is an inflammatory condition, because inflammatory condition needs a bolus dose of steroid, vis-a-vis in CSR we will avoid steroid. So this differentiation is one of the most important striking feature. So if anyone has any specific comment on this, we will, otherwise we will move on to our next topic.
No, I just want to ask, can I just ask Manisha or Mohit? See, I think in this condition, it's very responsive. Do you need to give 1 milligram per kg, or do you give an anti-inflammatory dose, which should be, let's say, 40 milligram in an adult male would have been probably enough, because they do respond very well. That's what I wanted to ask you.
So I think Dr. Hemant will go with the full dose of the steroids.
Okay.
And I think that would be the ideal thing. And like Mohit mentioned, that the threshold for giving an immunosuppression subsequently in the form of maybe an Azoran or something like that would be preferred, because there is a very high chance of recurrence in these patients.
Okay.
And they can be left with a RAPD, sir, akin to optic neuritis. If the bulk of the scleral inflammation to begin with was at the back of the eye, surrounding the disc, we might get absolute spectacular resolution, which is generally the norm. And we can get 6966 for the most part, but they can and might be left with a residual grade 2 RAPD. So there is a functional defect which is left there, akin to optic neuritis. And if they get a recurrence, then again, akin to, there will be added kind of thing on top of that. So if we are instituting immunosuppressive therapy starting at 40 and doing a regular taper, I think our window for the IST to try and act and our steroid dose to come down, I think that window is narrower as opposed to 1 mg per kg conventional tapering. And then the IST also gets time to kick in, sir.
Yes.
Sorry, go ahead, Raji.
So for the general ophthalmologist, the reason why they missed is they looked at only a subretinal fluid, nothing beyond the subretinal fluid. So that's how they missed it. So when you look at an OCT, looking at subretinal fluid is one. Second thing is looking at intraretinal changes, what is happening. More importantly, looking at choroid is also important. So if you look at choroidal thickening in central serous retinopathy, it's a diffuse choroidal thickening which is happening, and there is no elevation like what we have seen in this patient. This patient had that choroidal elevation which is there. And again, VKH can have choroidal elevation, but there are multiple bumpy elevations. And there is a clear choriocapillary seen even in this scan. So this shows that there is an inflammation in the sclera, which is pushing the choroid up, not the choroid itself as involved directly to start with. So I look at the choroid and choroidal features, you'll be able to differentiate whether you're dealing with what type of choroidal involvement, what is happening there.
Very good, very true. Yes, Dr. Manisha, you are telling something?
No, I was just saying that with the kind of the huge choroidal bump that was being seen on OCT, I wanted to ask Dr. Abhishek that did he appreciate any kind of an elevation in the clinical examination, because that is what is going to be causing the choroidal folds that you were mentioning.
It was not very evident, ma'am. The bump was not very evident.
Right.
Ma'am, I just want to ask another question. Do you start IVMP in these cases, or do you just give oral steroids?
Well, if it is involving the macular area, I would not hesitate in starting the IVMP.
Thank
So
you.
more than that, in this case, if you look at it, there is hyperemic disc and possibility of optic now getting involved.
Yes.
So better possibility is to give actually an IVMP rather than just giving a oral steroids and wait for it to act.
Yeah, it depends upon the amount of the inflammation is there. So, or at least if you start with the oral steroid also, there is no harm. That's what Dr. Manisha, you are looking for?
Yes, I mean the ideal situation, if you have the facility, IVMP would be the best option. But if it is not available, then to go with the full strength of the steroids in the form of 1 milligram or 1.5 milligram per kg body weight is the best to start the patient on oral steroids then.
And immunosuppressive to be reserved in case of recurrence.
Yes.
Okay.
Can
Okay.
I make a small point?
Yeah, please.
It's Vinod here, Dr. Rupak.
Yes.
So I think it was a lovely presentation because it is this whole webinar is meant towards general ophthalmologists and postgraduates. The very important issue here is a good, complete ophthalmic examination and history should be paramount in each and every case. As Dr. Abhishek said, the patient's complaint of pain was kind of ignored. Now I think over a period of time we all have gone through residency and we have done all those things, but I think patients' symptoms are the paramount and we must not ignore them, especially since we are talking about micropsia, metamorphopsia. I think few of the conditions where we give more weightage to the patient's symptoms, metamorphopsia like myopic CNVM, rather than actual finding. So that is one thing. And second thing, I think Dr. Rajiv said it very nicely. Not every SRF which you see on OCT is CSC. It's like fever could be caused by a number of conditions. Fluid at the macula can be caused by, I think, almost every disease, and you must take it into the with the entirety of the clinical picture and not just the face value of the subretinal fluid. Thank you.
Okay. We are actually running short of time, so we'll move on for that, and we'll move on to our next presenter, Dr. Bhaskar Ghosh. He is Chief of Retina Service at Location and the Eye Foundation, Purulia, and Retina Services, Consultant Retina Services at Renuka Eye Hospital. Dr. Bhaskar, the podium is yours. Can you just
Hello, sir.
share your presentation? This is one of the most important, please make it into the slide share, please. This is one of the important presentation for the Journal of Ophthalmologists as well, pseudophakic CME, and most of the cases they are having the underlying DME or a mixed pattern also. So how to differentiate whether it's a purely pseudophakic CME or you are actually dealing with a diabetic macular edema, and the treatment modality will be different. So we will go for that. Dr. Bhaskar, please.
Thank you, sir. Good evening. Today I'll be talking on the pseudophakic CME and how to differentiate it from the diabetic macular edema. So our case, a 52-year-old female patient who presented at our OPD with dimness of vision for the last 1 month. She had an uneventful phacoemulsification surgery around 4 months back, and there was initial visual improvement after surgery. There was no significant systemic comorbidities. The intersegment findings were unremarkable. The IOL was in situ and the IOP was normal. The fundus was otherwise normal, only the foveal reflex was dull. Here is the fundus photo. The OCT showed few intraretinal cystic spaces, and the FFA showed some pitelloid leakage and also the late disc leakage. So the pseudophakic CME or Erving-Guest syndrome is the most common cause after uneventful cataract surgery, caused by the accumulation of fluid within the retina after uncomplicated surgery. There will be cystic spaces mostly in the outer plexiform and inner nuclear layers, and typically it presents 4 to 12 weeks post-op period. Though the angiographic and OCT detected CME is as high as 30 to 40%, the clinical CME, where the vision is 6/12 or worse, is very few, only 1 to 3% after the uncomplicated surgeries. The common symptoms are the dimness of vision, the loss of contrast sensitivity, and metamorphopsia and central scotoma. And on examination, we normally found the foveal depression, loss of foveal depression, and foveal reflex loss, the intraretinal perifoveal cysts on slit lamp biomicroscopy. Though if the edema is less than 300 micron, it is not detectable by the biomicroscopy. Only retinal imaging can reveal this. So most common risk factors are the complicated surgery, and mostly the posterior capsular rupture with vitreous loss or vitreous fraction at incision site, or retinal lens fragments, iris trauma, and a few systemic factors like diabetes mellitus, uveitis, and RVO, and few anti-glaucoma medications also can cause these symptoms. Mostly the inflammation caused by cataract surgery, which triggers the arachidonic acid release from uveal tissue, and which ultimately produces the prostaglandins and leukotrienes, different types of prostaglandin, which ultimately causes the breakdown of blood retinal barriers and fluid accumulation in inner nuclear and outer plexiform layers. So it's very important to determine whether the case is of true Erving-Guest syndrome, or it's a diabetic macular edema, or it's an overlap of the two syndrome. So why it is important? Because even in the diabetic patients, the common cause of visual decline after cataract surgery is this Erving-Guest syndrome. And there's a multiple clinical overlaps between these two. And the misdiagnosis may delay the appropriate treatment, and mixed mechanism frequently encountered. So how to differentiate between these two phenomena? In the pseudophakic CME, we can get mild retinal thickening, minimal hard exudates, or mild disc hyperemia, or minimal or no vascular changes. In case of diabetic macular edema, we will get hard exudates and dot blood hemorrhages, microaneurysms, and several others NPDR or PDR changes. In OCT, in case of pseudophakic DME, CME, we'll get large cystoid spaces, predominantly in the inner nuclear and outer plexiform layers. Also, it will be in pitelloid arrangement, and central cyst will be disproportionate to the diabetic retinopathy severity. Also, the subretinal fluid also present in this case. In case of DME, the retinal thickening will be diffuse, and there will be multiple smaller cysts. There will be hyperreflective foci, hard exudates will be there. Also, there will be DRIL and ERM and VMT. There's an important study which differentiated the diabetic macular edema from pseudophakic cystoid macular edema by only the OCT. Here is some important outcomes of the study. And how to differentiate between the two by FFA findings. In case of pseudophakic CM, you will get peteloid perifoveal leakage in the early phase and late optic disc staining. It's very important. It strongly suggestive of pseudophakic CME. This late optic disc staining. In case of diabetic macular edema, we'll get the microaneurysm leaks or diffuse leakage, capillary non-perfusion areas, and few ischemic areas also. There will be mixed mechanism disease also, where many diabetic patients will present after the cataract surgery with pre-existing DME. This cataract surgery will cause some inflammatory trigger, which ultimately results into overlapping OCT features, is variable anti-VEGF response, and they will need individualized treatment. So how to manage these cases? In case of predominantly pseudophakic CME cases, the first line of treatment is topical NSAIDs like Nepafenac, Bromfenac, or Ketorolac, or the topical steroids like prednisolone or difluprednate, or the combination of these two, because they both have synergistic effect when used together. If persistent pseudophakic CME is there, we can opt for the posterior saphenous steroid or oral acetazolamide or intravitreal steroid like IVT or Ozurdex implant. In case of predominantly DME patients, the first line treatment nowadays is anti-VEGF therapy. There's lots of options in this category, and we can consider steroid when the patient is pseudophakic or he or she is poor responder to the initial anti-VEGF therapy, or we suspect strong inflammatory components there. So this is the protocol of pseudophakic CME management. There are a few studies which compared the efficacy and safety of Bromfenac, Nepafenac, and other NSAIDs, but there is no clear-cut advantage of one over the other. Surgical managements like pars plana vitrectomy are not the first-line treatment. It's only preserved for the chronic and refractory cases. When the patient is also have the VMT or ERM associated, also the anti-vitrectomy or ND-YAG laser vitreolysis are reserved for the incarcerated vitreous stands also. In case of retained-less material or malpositioned subluxated in sulcus lenses, the surgical management are preferred. So the take-home message here, the history of time of presentation is very important. The OCT morphology is the key differentiator between these two phenomena, and the disc leakage on FFA is favored strongly to the pseudophakic CME, and most cases resolve spontaneously within 4 to 6 months with good visual outcome. But early steroid and NSAIDs have important preventive role in pseudophakic diabetic patients, and large cysts disproportionate to the diabetic retinopathy severity after cataract surgery strongly suggests this Irving-Guest syndrome. Thank you.
That's a great presentation, Dr. Bhaskar. I mean, you have nicely depicted how to differentiate. I will go to Dr. Saurabh Sinha. Would you please, tell us how to differentiate between Dr. Bhaskar has told, but I think one of the important parameter before going for the OCT, the clinical examination and slit lamp biomicroscopy is one of the important parameter by which you can differentiate between those two. So, Dr. Sinha, if you can throw light on this.
We talk about two different conditions. One is a patient who has no diabetic retinopathy and pseudophakic CME. Sometimes it's clinically a little difficult to figure out what's happening. Definitely for the general ophthalmologist, be very low threshold for an unhappy cataract surgery patient to get an OCT done. So I repeat again, for the general ophthalmologist, any unhappy patient after cataract surgery with the quality of vision, get an OCT done. On your examination, look for the microaneurysms and look for the minimal hydrocephalus, if any. Then you're probably looking at DME. We also have a category of patients who worsen the diabetic macular edema after cataract surgery. That's more of a, it really doesn't happen so quickly, and we talk about it more, we don't see it so much. So again, take home message for the general ophthalmologist: examination of the macula with the slit lamp microscopy, not with the direct ophthalmoscope. Of course, you get a magnified image, but a biomicroscopy with the 78 or a 90D, whatever you are comfortable, to look at the edema over there, and definitely an OCT is what is going to help you out. That's all.
Okay, there was one request from Dr. Santosh Honavar is there for the general ophthalmologist. See, what are the actually a patient, like today's topic mainly is a walk-in patient with a metamorphopsia, micropsia, macropsia. So a patient comes, so what is actually we should look for, or what are the cases are there that you should look for? So if you can just give us a outline for that key. A general ophthalmologist who has just completed MS and in her practice, his or her practice. So what they should look for?
You want me to answer that?
Yeah, please.
Okay. So very important. Some of our findings are very obvious. A CNVM, a choroidal membrane, where there is some little blood over there, grayish thing. You know this is CNVM. You're looking at that. Sometimes it's much less subtle than that. So one would be a choroidal membrane, which could be most commonly in the younger myopic patients. It's a myopic CNVM. In the elderly group, it's possibly a ARMD related or PCV. I'm not getting to that. But any blood reddish heme over there, you're looking at a CNVM. That can cause a metamorphopsia. The first case that we talked about, even with is a central scotoma, central area, dark area, it's a CSCR. More rarely and less commonly is a macular telangiectasia, where you can have distortion, patients are happy with the glasses, and you may not find something very clearly. If you can find a small black pigment over there, a very dot pigment over there, or maybe some glistening reflex over there, it looks a little grayish, you're probably looking at a MACTEL over there, macular telangiectasia. Again, an OCT will help over there. These also, one commonly mistaken or missed one is a small venous occlusion. A small venous occlusion can cause, again, a little, we look at it very casually, sometimes look at the 78D, you might miss that. So look at the very carefully. And I go back to old school thought is to keep the mainster lens in your OPD. So when a contact lens, putting it in, if you have it, is fantastic, because that will give you a much clearer. And I keep saying this, if you are very confused today, I still feel some of us, or most of us, if you use the mainster carefully, we will get more information than from an OCT. Sometimes an OCT is more confusing, and if you see clearly by yourself on the macula, I think this is what will help us very much.
Can I add? See, the for the postgraduates, I think the most important thing is once you have micropsia, metamorphopsia, or any of these symptoms, it indicates a macular pathology. And that is one thing that you should always remember, that one patient who complains of it, there is a macular pathology, which could be epiretinal, or that is a vitreoretinal interface problem. It could be within the retina. It could be in the choroid. So any of these causes can produce it. So that you need to differentiate. And clinically, one can make out by various signs that one can see when you do a good 90D examination. The next is to do a OCT. If one has it, that would give you the diagnosis to where your lesion is. So I think you have to go systematically. It's like entire macular pathology would come to this, we have presenting with these symptoms. So one should remember it's a macular pathology. So once that is there, I think you should start going about in the diagnosis.
Yes, absolutely. And in our presentation also, we are giving you some kind of these macular pathology showcases. So at the end of this webinar, I think they will have a good idea about how to proceed about a case of metamorphopsia cases. Okay, so we will different now the diabetic maculopathy, if it is there, if it is a combined both diabetic maculopathy, Dr. Hemant Murthy, please, if you answer, if you have a diabetic macular edema and the pseudophakic macular edema combined, so I mean what should be for a general ophthalmologist? Now they can be confused that should I treat the pseudophakic macular edema first or the diabetic macular edema first, or should I treat both of them? So what is, if you can just tell us what should be the way of managing these cases combined both DME and CME?
So one of the ways that you can, start looking at the patient is examine both the eyes. That will give you a clue on what is the extent of diabetic involvement in the patient. So once you have an idea, whether there is any diabetic changes that you observe clinically, then there is a possibility of it having also a diabetic macular edema. So if there are no changes, you don't see any microaneurysms near at the macula, and the other eye also does not show any changes, then the most likely, and the time sequence is what is critical, most of them present at a very peculiar time around 3 weeks or 4 weeks after the cataract surgery, wherein they start having this blurring of vision. So they would tell you that they had good vision after surgery and then it deteriorated after that. So that's a very typical symptom that most patients come. So having done that, I think Dr. Bhaskar did explain on how do you differentiate the two on the investigation side of it. But a simpler way is you do a good clinical examination, you do find some clues of what is your diagnosis.
That is absolutely. And the absence of diabetic changes, that what you have absolutely mentioned in either eyes, that is giving you the clue that it is probably a pseudophakic macular edema. But in diabetic patient also, the pseudophakic CME is chance little higher. So that also we need to keep it in mind.
That is just what I was going to point out, because that's
Yes.
an entity in itself.
Yeah.
Yes. So because of the vascular leakage per se, that can lead to these changes. And we are not going into detail of the treatment of DME here, because the main idea is to treat it off. For treatment of DME, if you can, Dr. Manavi, if you can just give us a very superficial guideline for in few sentences of DME treatment protocol.
Yeah, thank you very much. I'll be just keeping my camera off since we have a current failure in my area and I'm in semi-darkness. Yeah.
No.
So for DME treatment protocol, I think in the evaluation is based mainly with an OCT evaluation to quantify the amount of DME and to follow up the response on treatment. And the first line of treatment in today's era is an anti-VEGF injection. Ideally, a loading dose should be given to the patient, which will depend upon the drug that is chosen. And the treatment has to be continued with regular injections until a resolution of the edema or at least a stabilization of the edema is noted on serial OCT scans, following which we can go to ideally a treat and extend or a treatment as PRN. For non-center involving DME or as an adjunct to anti-VEGF therapy, a focal or a grid laser does have some role, especially I'm quite fond of it in non-central involving DME, where you have a lot of leaking microaneurysms which give rise to cercinae, because these can slowly leak over time and the hard exudates can creep into your macula. Patients who are presenting to you with either a very chronic DME at baseline or who have a poor anti-VEGF treatment can be considered for steroids. Of course, we have a lot of anti-VEGFs in our armamentarium now, right from, ranibizumab and its biosimilars are there, but then we also have aflibercept, we have Pejanax, and we also have Vabysmo now. The non-response rate has reduced, but in those patients, of course, and since DME has an inflammatory component, steroids do work well, and also the Ozurdex implant gives a little bit of sustained amount of time for response and works well. The DME patients can also have coexistent renal pathology and cardiovascular pathologies, and in these cases, you may need to consider the steroid as a first line of treatment.
Yeah, that is absolutely bang on, Dr. Manavi. Thank you so much. We'll move on to our next
Rupa, can I make one last comment?
Yeah, sure.
So I think for the general ophthalmologist, if despite everything you are confused whether you are dealing with DME or a pseudophakic CME, we need to understand that the treatment of DME is no emergency. And initially after the cataract surgery, I think we should, if we see that there is a significant amount of macular edema, just hold your hands back from giving anti-VEGFs or going on the line of DME treatment. Give adequate 2 to 3 months time with just NSAIDs for the inflammatory component of the macular edema to subside. And it is only after 2 to 3 months, if you find that there is a persistence of the edema, then probably you have to err on the side and consider that as a DME rather than a pseudophakic CME.
Correct. I agree with you. I completely agree with you. We'll move on to our next presenter, Dr. Harshit. Dr. Harshit, are you ready now? Yeah, can you start sharing your presentation? Dr. Harshit from Dr. Vaidya Eye Hospital, Mumbai, and he will be again one of the most important cause for the metamorphopsia is CNVM. So he will steer us through those cases.
Yes, sir. Is my screen visible, sir?
Yes, please go ahead.
Okay. Good evening, everyone, and thank you, Rupak sir and Piyush Bhai, for this wonderful opportunity. So before we delve into the cases of CNVM and dive further into it, I think it's important, imperative to understand that the nomenclature has recently changed from the traditional CNVM to the MNV, which is actually a macular neovascularization. This is an apt name simply because it's the area that we are talking about and not the layer, because we know that neovascularization can happen both in the retina as well as in the choroid. So the correct nomenclature now is the MNV as opposed to CNVM. Delving right into the case, the first is a typical patient, 62-year-old female, walks into the clinic with distortion of vision, the metamorphopsia that we are talking about in the left eye. And on the clinical examination, we see a typical, number of drusen in this whitish membrane here. The OCT, obviously, as a general ophthalmologist, armamentarium, clinches the diagnosis here. But just a little more delving deeper into it, we see that there is an elevation of the RPE, the subretinal fluid here, as well as the drusen. But if we see the RPE layer here, which is elevated, just underneath this, there is a heterogeneous sort of reflectivity here. Basically, this is where the membrane lies. And on the octa, we can beautifully see the network here. And this is a type 1 CNVM or an MNV. The terminology which we'd be using now is the exudative MNV, and these patients obviously need a loading dose of anti-VEGF for their treat and extend or PRM. So the purpose of this case to share was not just the left eye, but it's the right eye. This would pass off as an easy case of dry AMD. But an OCT, if we see here, there is this elevation here again. This is like an irregular elevation. Again, there is some heterogeneity here. Now, this particular case on the octa shows a network. Again, this is an important entity because it needs to be distinguished from the exudative part. Although there is a network on the octa, this entity is called as the non-exudative or the quiescent MNV. These patients do not need an injection. So now with the armamentariums, with octa being more easily available to all of us, we'll be picking up these entities more often. But it needn't be that you're going to be injecting these patients. So whenever we see a patient of CNVM, what are we looking at when we are injecting, or how are we modulating our treatment? We're looking for certain signs or activity. In clinical signs, you're looking at fluid, whatever thickening at the macula, the hemorrhage at different levels, and the presence of subretinal exudates as well. When it comes to the OCT, we are looking at fluid in the different compartments, the SRF, the IRF, and sometimes even in the sub-RPE component. The SHREM or the subretinal hyperreflectivity and the hyperreflective material, and the HRF, that is the hyperreflective foci. Now, this particular case of a typical case of AMD that Saurav sir was talking about with a heme, but this is a significant heme that we see at the clinic at the onset. This is a typical case of AMD this patient had, and we can see that both the signs, clinical signs as well as the OCT signs of the SHREM, the interretinal foci, and the exudates and the hyperreflective foci resolve with the loading dose of the anti-VEGF, which can be seen in these images. Now, this was a typical case of AMD. Moving on, this was a patient, a 66-year-old female, had this typical black spot and distortion of the vision in the left eye since about 2 weeks. This patient was passed off initially at a different center as AMD. Now, if you look at it just as a fundus finding as well, we see that there is a myopic disc, a slightly tilted disc, a tessellated fundus, and a subfoveal gray lesion here. Just a slight, like I think Vinod sir was talking about, delving into the history of patients. So just asking the patient before the cataract, the patient had a high minus number. So we know that these findings and the other eye being normal, apart from the myopic changes, points or should alert the general ophthalmologist or retina specialist as well, that we are not all age-related patients do not have AMD or CNV. So on the OCT, we typically see that there is an elevation here of the RPE, possibly a breach here, and the SHREM. So most likely we are dealing with a type 2 neovascular membrane here. And the reason to distinguish this is here we see on the octa beautifully that at presentation, followed by just 2 injections, the shrinkage of vessels can be seen, which coincides with the OCT findings. So the purpose of distinguishing these entities is to ensure that the number of injections that we may be counseling the patients for an AMD versus a myopic CNV may be different, and the counseling can be altered subsequently. This is just to show a few cases. This is again a CNVM, is not just AMD. This is a 42-year-old female with angioid streaks, and which has a high propensity. About 80 to 85% of patients of angioid streaks will have some sort of membrane in the due course of time. This was a case managed by a good friend, Jai, who was managing a case of serpiginous choroiditis. The patient presented with a drop in vision in the left eye and some metamorphopsia for about 2 weeks' time. On the FA, you could see that these early hyperfluorescence had some late leakage here as well. And on the OCT, a beautiful resolution just with 2 anti-VEGF ranibizumab biosimilar, where we see the resolution of the SRF and the SHREM. The patient restored the vision from 20/80, 20/30. Now, this is the last case I will be discussing, an interesting case which patient came for a second opinion, a 72-year-old gentleman considered as a wet AMD, seen by my very good retina colleague, a very competent retina colleague, and had undergone 3 intravitreal Vabysmo as well. And the patient was planned for the 4th. Now, at this particular time, the patient's vision was not getting altered because the patient, I think, had 3 injections. The OCT, he was a learned gentleman. He knew that the OCT is not really changing. So at that point in time, he was confused, and possibly that's when he came for the second opinion. And on clinical examination, we can see that there was this kind of a membrane here, some sort of irregularity. Drusenite kind of changes, but the OCT kind of clinched that there is no drusen here. There was this sort of SRF, some shaggy photoreceptors, and this RP elevation here. So at this point in time, because the colleague was competent, my mind was also in the fix as to maybe should I just switch the drug, or are we dealing with AMD? So like in any case, we look at the other eye, and actually this was possibly a clincher that the retina was perfectly fine. The OCT was spick and span, absolutely no evidence of any drusen. So this kind of should point us that we're not really dealing with an AMD case, because there is no frank sign of that. This is where the Octa actually helped us, where we found there was absolutely no network. So we just followed up the patient over the past 4 months, and there is no change in the fluid. Basically, this is not even a true fluid for all we know. This could just be a pseudo fluid, a case of possibly adult onset foveomacular vitelliform dystrophy, or possibly a pachychoroid disorder as well. But the patient was advised FAF and FA, but I think he was quite not happy with the injections and just wanted to not do anything further. So we're just keeping the patient under observation. So these cases, obviously at this point in time, we are just observing and not doing anything beyond. So just to take home 3 pointers, before we move on, like before we inject any patient of CNVM, on the OCT, it's always essential that we read the RPE line, see whether the membrane, if we can pick up if it's under or above, and look for evidence of activity, which we discussed. The second is that not all neovascular membranes are related to AMD. Look for other causes when things are not matching clinically, or the age, myopia, angioid streaks, inflammation, PFT, MACTEL, so to say. And last but not the least, which has been discussed by Rajiv sir as well, that not everything on the OCT, not every fluid needs an injection. Sometimes, when our injections are not working, it's a good time to revisit our diagnosis, stop a little, and then, do further investigation and plan a further treatment. So thanks a lot.
Thank you, Dr. Harshit. That was a very well, different type of CNVM cases has been described very nicely. I will go to Dr. Shobhit Chawla. Sir, can we just enumerate? My question to you is, number one is how they should differentiate whether it's a case of, they should diagnose that this is a case of CNVM, or a patient of metamorphopsia with subretinal hemorrhage. So what should be the next line of management, or next should be the plan of management for them?
Yeah, I don't think Dr. Shobhit is on. I don't think he's there.
Okay. I think he was there earlier. Yes, Dr. Hemant, if you can just tell us also.
No, can you come again? I was, please.
So my question is that when a patient comes with you a subretinal hemorrhage, and with or without changes of RMD or any point of time, so what should be the take home message that they should do? These are the investigation we should do before starting the treatment or referring the treatment, or when they should refer, the general ophthalmologist should refer them.
So any presence of hemorrhage, now the problem is that you need to differentiate. If you see hemorrhage at the macula, Just you need to first find out whether it is pre-retinal, intraretinal, or subretinal. So basically, one has to really differentiate. Primarily, one of the ways that you could do it is find out what is the possible cause of it. If there are any clues in the fundus which will point out towards one of these. Now, the other way that you all can do is to investigate is to, after you have done your clinical examination, you could probably pinpoint where it is, because sometimes there are hemorrhages within the retina, especially in any hematological disorders. So don't be misled that all hemorrhage is CNVM. So presence of hemorrhage does not mean that there is. It could be any of the other causes also. One way is to do an OCT, which will tell you what's the level of the after you have done a good clinical examination, which will tell you that. A final confirmation, if none of them are giving you the clues of what is happening, or let's say in a PCV when even the fluorescein does not give you, is to do an ICG. So that would be a way to go about step by step, because only then you can come to your diagnosis. I think predominantly most of them get resolved on good clinical examination and OCT. Some of them would require further investigation in terms of angiography, which one can do to find out the cause.
Correct. So we'll ask Dr. Vinod. Dr. Vinod, if you can just tell us, as Dr. Hemant said, ki most of the cases can be dealt with clinical examination and OCT. So what can be the OCT pictures in those kind of cases where you should confirm with the OCT that yes, this is a case of CNVM, or we should do an FFA, because OCTA is not available for the general ophthalmologist in most of the cases. So indications for FFA, what should be the clinical point or the OCT point where they should go for FFA?
I think that's a very important and relevant question in today's scenario, and very difficult to answer as well. Because while our earlier hitch was to, as soon as you see a fluid on OCT, you thinking of CNVM, the first thing we'll do is we'll do an FFA. And being in a center where we have everything, now that is the last thing I always do if required, for diagnosing or confirming a CNVM. Now that is something which has changed entirely over past decade or so. Especially I still do a lot of FFAs for diabetics and venous occlusions, but at least for CNVMs I don't do. Now, question comes to where there is a setup where you don't have Octa. Now, I think OCT gives us a fair amount of idea whether you have a CNVM or not. It's just that we need to see more and more OCTs and interpret them well. So, by and large, I think 99% of the cases you will be able to resolve with the OCT itself whether there is CNVM or not, and whether it is active or not. Now, a few scenarios where I personally feel FFA is very useful, despite OCT and Octa, is probably one is myopic CNVM. So those are the cases where you need to do FFA. If you have slightest of doubt, there's no harm in doing FFA. On the other hand, conditions like MACTEL, conditions like choroidal osteomas, FFA is not a very good pathology to detect CNVMs. Because picture is, you can say, phased by the underlying hyperfluorescence due to the underlying disease. So myopic CNVM, I think is the only condition, and probably a secondary CNVM due to, for example, you can say inflammatory CNVMs where there is a choroiditis. There is another indication where you can do FFA. It also tells you whether the underlying disease is active or not. So that is another added advantage of FFA in those conditions. By and large, I think most of other scenarios you don't need to do FFA if you know how to interpret your OCT well.
That is, I think you are bang on this topic. I'll just take one more opinion from Dr. Mohit. FFA, he has told very clearly that these are the two conditions where you will do. Now, you have started the treatment, Dr. Mohit, and then how do you follow up with the OCT, whether the CNVM is resolving or not? So what are the features of resolution of the CNVM? and you should follow up with the OCT and decide your treatment protocol. We will just remember that today's this webinar is mainly targeted for the general ophthalmologist, and because most of the expert panel and the chairpersons, what we are having all the armamentarium, so we will focus on how to guide them with this available armamentarium for the general ophthalmologist. Dr. Mohit.
Absolutely. Absolutely, sir. I'm going to just, confine my answer to wet AMD related MNVs, CNVs, and not the other ones.
Correct.
So there'll be two predominant kind of indications that we start therapy for in them. One would be hemorrhage, the other would be presence of fluid. Now, if there is hemorrhage and there was no fluid when we started injecting, then the endpoint has to be visual, so a slit lamp or / color fundus photo disappearance of hemorrhage. And of course, you're going to be monitoring the patients on OCT also if there is reappearance of fluid or not. Most of the time, there will be fluid and hemorrhage at the same time. You might not be able to see the fluid clinically. So in that condition, you have to have visual endpoint is that the hemorrhage has to go if there was one to begin with. The OCT endpoint, or if you want to treat and extend or whatever your protocol is that you have to try and look at the 3 layers as were talked about where you can have fluids. It can be inside the retina, it could be in the subretinal space, it could be in the sub-RP space. So you ideally want to try and ensure that the retina is the intraretinal fluid is dry, the subretinal fluid is dry, and the sub-RPE fluid is dry. If this is not possible with all treatment, you still keep injecting and changing and reducing the interval till the time that you have to have 0 threshold for intraretinal fluid. You can, if you've exhausted all your choices, or the patient is reluctant, or there are other factors involved, you might, if your back is against the wall, try and tolerate some amount of subretinal fluid. But definitely, if intraretinal fluid is there, your therapy is inadequate. If hemorrhage is there, your therapy is inadequate. And for the most part, initially, till you have exhausted all of your agents, yes, persistence of subretinal fluid, your treatment is still inadequate. I'm not going to go to Schrems and PED height because that would be a bit more. But these
Confusing.
3, I think, are important.
Yeah, I agree. And I think your take home will be, or the advice will be, for them to treat with the loading dose to start with, isn't it? Because that is one of the important factor for non-responder. So if you can't tell that it is not responded by giving only 1 injection. So for loading dose, at least we decide about the 3 consecutive months injection of anti-VEGF, whatever you decide.
Absolutely.
We are running short of time. The time is ticking. So we will move on to our next presenter, Dr. Janani Srinivasan. And Dr. Janani is a consultant at Shankar Nethralaya, Chennai, in the with retina department. Dr. Janani, please.
Rupak, Piyush here.
Oh, hi, Piyush.
Hi, sir. Can I make a quick comment? I just joined.
Yeah, before, please.
Thank you so much. So first of all, many congratulations to you. I missed Harsh's presentation, but I'm sure it was wonderful. Now, one point I would like to make is that, amongst all the topics that we had today, please pardon, I've switched off my video because I'm sitting in my gastroenterologist side room and just about to leave. So one of the most important reasons out of all of the cases that we are discussing today for metamorphopsia are macular neovascular membranes, CNVMs. So again, these are the patients that are going to require chronic I would say repeated consultations, repeated examinations, whether in the form of investigations like OCT, which are now available with everybody, but also angiographies or octas. But a message for all general ophthalmologists is that please make sure that you're referring these patients because these are the ones who are going to require explanations repeatedly about the current situation of their vision. See, we have not experienced this ourselves, but it's very important that we try to empathize with the kind of changes in the quality of vision that these people are experiencing over a period of time, whether they have hemorrhages, whether they have edema. I mean, there can be so many presentations that they have. I think the rest of the relevant inputs have already been given. Mohit was spot on, and I'm sure the others were also. So this is just one small caveat that I wanted to put out the general ophthalmologist, that amongst the diabetics, amongst the people with pseudophakic macular edema, see, it's comparatively more predictable. But with the CNVMs, many a times it's unpredictable. The way that patients are going to look at the world or visualize is going to change even if they resolve. So please make sure that you all are referring these particular patients in time, and these patients will continue to come to you as a general ophthalmologist, but also make sure that the retina surgeon keeps looking at them. I hope I made sense, Rupakda. Back to you.
Yeah, thank you, Piyush, and thanks for your commitment. In spite of you are not well, please take care of yourself. We will just move on to our next presenter, Dr. Janani, please.
Good evening, sir. I think Dr. Piyush made the best intro for my talk. So we'll be seeing these patients, MACTEL patients who have metamorphopsia, and when they come for follow-up, they'll be progressively depressed. So what are the multimodal imaging pearls for this? Thank you, Rupak sir, for giving me this opportunity. Now I directly go for the cases. Here is a 64-year-old male, lost his one eye due to trauma, childhood trauma. Now he's presenting with metamorphopsia, very mild, but since he's one eye, probably he picked very early. When we see the fundus photo in OCT, not much, some age-related RP changes. When I saw, I initially dismissed that nothing much, sir, you're good, we'll follow. But then this patient was very persistent. No, this problem I did not have earlier. I'm having only for 1.5 months. Something is there, and I'm not happy. The one patient, it keeps on opening the door in the OPD, isn't it? So then I thought I'll do an Opta for whatever it's worth, nothing much again. So then I did multicolor imaging. I'm very fond of this imaging of late. So when we see this patient has this typical PFT kind of picture, I once again go back to clinical picture for understanding. Not much changes. Again, the same eye, when we look at the multifocal, we are able multicolor imaging, especially this the blue reflectance, we can clearly see this loss of retinal transparency, which is actually seen clinically. This is because, as we all know, this is the wavelength that corresponds to the foveal pigments, which are lost very early in the disease. Thus, confocal blue reflectance enables the detection of early disease. Now, I had nothing much to offer. At least the patient went with an answer key why this patient had problems. So, it is important to choose right modality. Now the second case, again a 54-year-old female, she came with 3/60 and 6/9 in OS. Now this patient had already a known case of, actually she was diagnosed as some dry AMD outside, and she knew she had some problem in the right eye. But her complaint was that there is some recent deterioration. Now, when we looked at the cone blue reflectance, we can clearly see this is PFT. We can compare in both the eyes, compared to all other colors, like one is multicolor, one is infrared, this is green, and this is blue. We can clearly see the changes very well in blue. Now, again, this doesn't explain why there is a sudden drop in the right eye. Now, again, OCTA, 6mm scans show that foveal thinning is there. Probably thinning is more in the right eye, which nobody can deny. However, why this sudden change happens? Now, 3mm scan, which is a magnified version of the previous image, where we can clearly see that there is a network at the outer border, which is the supranasal portion of the fovea. So this must have caused the recent metamorphosia in this patient. However, there was no fluid. The patient was given two options, one with injection, because she was very particular that this was a sudden change, type 2 membrane again. The other option is to closely watch. The patient is yet to come after observation. So it is important to look at the right area with the right magnification to pick up the cause for metamorphosis. So for the comparative image, I have put the left hand image is 3mm scan and the right is 6mm. Now we can clearly see the network here. Now, another is the case 3 is a 65-year-old male, diabetic hypertensive. Again, metamorphopsia only in the right eye for 1 month. When we have a closer look, one can appreciate few microaneurysms, something like a cyst or pigment. Clinically, it was more looking like a roundish lesion in the right eye. Left eye was fairly okay. So we all thought probably some DME. Actually, when we look at the multicolor imaging, one can appreciate that there is some temporal loss of retinal transparency in both eyes. Okay, fine. And more so, if you look at the right eye, the green reflectance is showing the microaneurysm. So thus we can use the different color reflectance imaging to pick up lesions from different layers. Like green, always we, even in the examination, when we see in red free, we appreciate more these microaneurysms, neurosensory detachment. Same concept we are exploiting here. So we are able to appreciate more microaneurysms. Whereas in the blue reflectance, the microaneurysms are not appreciated well. Whereas a loss of retinal transparency is appreciated more. So coming to back to our question, why this metamorphosia happened. Now ORCC, this is a octa, it is showing some cavitation fine, but there is some lesion juxtafoveally which is taking up some flow signals. Probably some microaneurysms, but it is too big. So what are we dealing with? When we have a closer look, it is looking more like a shrum, that is a subretinal hyperreflective, or should I clearly put it as it's more intraretinal hyperreflective material, taking up again only the retinal flow signals. Just for understanding, so the red is mostly retinal blood vessels and the green is choroidal blood vessel. Here we see more of red. So now the octa image, I just want to show again, not picking up any membrane here. So again, we thought, what is this we are dealing with? And little bit we went in the mission and tweaked a bit, and we found a network in the avascular slab. So avascular is more inner retina, just for understanding. So we all know the CNVM associated with PFT starts from the deep retinal layers and then it descends down. So probably we have looked at this patient when the network started to form. So that thus we found the network at the avascular slab. It's not only important to look at the right place, not only at the right magnification, but sometimes at the right slab as well. Sometimes we go through the entire video of the OCT, which starts from, superficial, deep, avascular, RP, choriocapillary. So we may have to do in selected cases. Again, this patient was closely observed. So this is a last case where we can see a 36-year-old male presented with bilateral metamorphopsia for 2 years. This is very interesting because this patient was diagnosed as CSCR. The same SRF, this picture what we are seeing was there for the past 2 years in different color OCT from different missions from different institutes. Nothing has changed. He has received almost 6 injections. No change at all. My first question was, even if it is some neovascular component or some CSR, there has to be some change. The fluid should resolve, the fluid should increase. Nothing, basically nothing. So then we went ahead with the investigations, multicolor and the superficial and deplexus. It all confirmed the diagnosis of PFT. We can see clearly the loss of retinal transparency here. We can see intraretinal crystals. So this is PFT. Yes, fine. But why fluid? Again, we went ahead with octa. I have checked in the mission through all the slabs. No network, absolutely. Now we are stuck. So this is a PFT. Yes, fine. But why fluid? Is there a membrane? No. And what about previous experience? No change with injections. Now, when I went into literature, there have been reports where PFT is associated with NSD, although not this symmetrical. And this we have published also. So this is a slightly atypical presentation where there is a subretinal fluid without a network. So nobody knows how to manage this entity exactly, but most of the cases were observed. So we have to be aware of atypical presentations as well. So we have to choose the right modality. We have to look at the octa at the right slab with the proper magnification. We have to look at the correct area to identify the membrane. Not only all this, we should also be aware of atypical presentation to clinch the diagnosis. Thank you for your patient listening.
Yeah, that is a very exhaustive, but it is very different variety of MACTEL presentation, Dr. Janani. We'll go to Dr. Rajiv. If you can tell us, this is most of the time we see the symptoms are more compared to the signs here. That is the typical for the MACTEL presentation. Dr. Rajiv, if you can, until you have a advanced stage where the CNVM or the pigmentary changes has happened or the scarring has happened. For the initial phases, so what will be the clinical feature and slit lamp biomicroscopic examination as well as the OCT features that gives them the diagnosis of MACTEL? Dr. Rajiv.
Yeah, so in MACTEL, most of the times when you have a cursory look, when in early stage, you might miss it. So what we have seen is if you do an autofluorescence, you will see an early changes which you pick up on an autofluorescence, where you lose that central hypoautofluorescence. That's one of the earliest features which you might see. Other thing is when you are examining the patient, you see a subtle grayish tinge onto the fovea, all around the fovea. This is another feature which you identify when you are examining the patient. Sometimes if you have a high magnification looking at fovea closely, you might not get that graying of the tissue around the fovea. So you do an indirect ophthalmoscope, you will be able to find that more easier. So these are the things which I would say pick up first. And when you do an OCT, the earliest changes which you see is only a thinning of retina. Very few telangiectatic vessels are little later stage you might start seeing them. But earliest I would still say that graying of the tissue around the fovea, or maybe one small area, or increased cloudiness to the retinal layers. And on autofluorescence, you might see earliest loss of hypoautofluorescence in the center.
Yeah, I think absolutely correct. So the indirect ophthalmoscopy, most of the time, you have that doubt of MACTEL whether you are dealing with. So that is a perifoveal white halo, what we usually describe, or maybe a complete or incomplete, especially on the temporal side of the fovea. That is one of the suspicion. And the OCT is having a typical square shaped areas of cystic spaces, which is unlike to the other CME where you do. Most of the cases, a general ophthalmologist can get confused with these cystic spaces compared to the CME. So how to differentiate between these cystic spaces and the other cystic spaces?
Yeah, so the first thing is like what you said, it's a square shaped lesions. And second thing is when you see the cystic spaces like this, and there is no increased thickening of the retina there. Retina might remain the same thickness or maybe less.
Correct.
Though in spite of having a cystic space inside, usually if you have a fluid accumulation, you have a cystic space and causing an increased retina to thicken up. Whereas here it's a degenerative cyst, so you don't see a thickening of retina, but in fact it remains same or it becomes less.
So most of the cases, even with this, also we are not able to do anything. Dr. Manavi, even if you have like this kind of cystic spaces, and you are not patient is having symptoms of metamorphopsia to some extent, but there is no significant changes of the visual acuity, maybe 6/12, 6/9 vision. What will be your plan of treatment? Observation or injection? Does injection help at all in these kind of cases?
Yeah, the plan of management would be observation because injection doesn't really help unless there is a presence of a neovascular membrane which is seen, which can be early, like when Janani showed some very nice images. So as Piyush just mentioned before her talk, these are one of the patients where you have to talk a lot to them. It's also a very odd entity which is difficult to explain to a patient in a layman's term as to what is actually happening to their retina, as well as they do have even drop in vision sometimes to a significant extent, especially when pigment plaques appear. And in those cases, you're still talking to them that yes, you have a condition which is genetically predisposed probably, and you will have low vision, which can sometimes even keep deteriorating. But the only thing is, if at all you do develop a membrane, we can do some treatment. There has been trials of injecting even in the pre-proliferative stage, but none of them have shown any difference or changes. So yeah, we observe and we counsel and talk to the patients.
Correct. So we are moving to the next topic. Before that, we'll have a quick opinion from Dr. Saurabh Sinha. Most of the cases, they can present with a lamellar macular hole, or maybe sometimes looking like a full thickness macular hole when these degenerative changes coalesce together or they merge together. So in those cases, what with a significant amount of the good vision, 6/12, 6/18 vision also. So do you think that these kind of cases by doing surgery of macular hole surgery, it helps at all?
Before I answer the question, I'll quickly go on a much lighter note on a more 2-3 points I'll make very quickly, which I've made to the postgraduates. The general also, any patient, and this is just for remembering things, fat female fertile 40 Any patient saying, I've changed my glasses thrice, 4 times in the last 6 months, 1 year, and none of the glasses are suiting me. Any patient where in the good old days, we look at the fundus and before we say dull FR. So I think the dull FR is again a giveaway that you could look at the PhD. So these very simple signs, very simple symptoms that you look at when you think of a MACTEL. You can't see any patient very unhappy, exactly what Maria was seeing earlier, a patient not leaving your OPD, coming back again and again. I think that's very important. Please look at those few things. Also, some of your patients' material letters are jumping, which doesn't really click in our minds immediately, but this is possibly a patient of active because you clinically can't see anything, obviously, and you've still not thought of getting an OCT done. Now, coming to your question specifically, surgically, the patient understands that this is a touch and go thing, it can get worse over time. Offering surgery may not be a good idea, may not be a bad idea, can offer surgery, but you need a follow up on this, and before it gets to a plaque or that sort of operation, surgery can be offered to these patients.
Okay,
Saurabh,
so we'll move on.
make a point.
Yeah, sure.
Thank you, Rupak Da. First of all, I mean, fantastic point. 3 Fs. I'm going to remember it for the rest of my life. So thank you, Saurabh Da, for that. This was a fantastic presentation. I saw the most of it, and absolutely fantastic, Dr. Janani. What happens is, I mean, just deflecting a little bit. This was more centric towards the investigations part. Now, how does a general ophthalmologist try to pick up the PFT or macular telangiectasia in the clinic? Now, this is what I learned in my initial fellowship days with Dr. Rajiv, with Dr. Rajanarayanan. And what Dr. Rajanarayanan would say was, you keep looking at the macula. Even if it is with a 90D, you keep looking at the macula, follow the curvature of the vessels. Now, that is a very important point, that, you know, a normal curvilinear progression of the vessels changes in these particular cases. You notice a straight, a very prominent deflection, whether it is 90 degrees or whether it is less, but that deflection is definitely there in these particular patients. So for general ophthalmologists, you look at the curvature of the vessels at the macula, and that should point you in the right direction. I mean, suspicion can be pursued after that. Once you have something in mind, then you pursue it with investigations, whether it is the OCT, whether it is doing an angio or octa after that. But looking at the macula, sometimes it is difficult to pick it up with an indirect, and we are used to it because we zoom in even with the indirect at the macula. But even if you're looking at these kind of patients on slit lamp biomicroscopy, taking a little bit of extra time, maybe 10-15 seconds more, and following these vessels can give you a clue into macular telangiectasias. Thank you, Dada.
True, very true. Very true. We're just making a little changes in the presentation because Dr. Subhashini's presentation is also similar kind of a intraretinal component. So we will go to Dr. Subhashini first and then Dr. Shubham. So Dr. Subhashini, can you just start sharing your slides, please?
Yes, sir.
She will be presenting a cases of PAMN or AMN cases, which is also having a very less clinical features, but the patient is symptomatic. So Dr. Subhashini, please.
Yeah. Are my slides visible?
Yes, please go ahead.
Yes. Good evening, everyone. At the outset, I would like to thank Dr. Rupak Biswas and Dr. Manvi for this opportunity. Today, we'll be seeing the case of a series of cases of paracentral acute middle maculopathy. Coming to the first presentation, it's case 1. He's a 47-year-old male patient coming with complaints of diminution of vision in the right eye, mostly. Right now, we can see that the visual acuity in the right eye is 6/6, and in the left eye, it was 2/60. There was a previous history of central retinal artery occlusion in the left eye, which was responsible for the low vision. And there is no other significant systemic history in this patient, even though he was evaluated before this. The history of diabetes, no documented hypertension. The anterior segment examination was completely normal. Yeah. Coming to the fundus examination, we can see there's a subtle perifoveal whitening in the area in the right eye near the macula, and left eye features are suggestive of CRAO sequelae. And coming to the OCT examination, we can see there's a band-like hyperreflectivity, which is confined to the layer of the inner nuclear layer, and the outer retinal layers were preserved. The RP and choroid are looking almost normal. And in the left eye, there is thinning of the inner retinal layer, suggestive of post-CREO sequelae, and the pattern is consistent with ischemic injury. A provisional diagnosis of right eye acute paracentral acute middle maculopathy was established, and the patient was completely evaluated again with a complete cardiovascular evaluation with ECG, 2D echo, carotid Doppler, and lipid profile and everything, which has turned out to be normal. The second case, we have a 39-year-old gentleman complaining of defective vision and blurring of vision in both the eyes since only 20 days. The best corrected visual acuity in the right eye was 6/18, and in left eye it was 6/9. There was a recent history of myocardial infarction, which was just 20 days back, and he's a known hypertensive, was under treatment for almost 2 years. Other systemic profile evaluation, including CBC, diabetic profile, and lipid profile, were all within normal limits. Anterior segment examination was unremarkable. Fundus examination of both the eye showed superficial retinal hemorrhages, multiple cotton wool spots, and RP alteration at the level of macula. There's no optic disc edema, even though the clinical picture looked almost like hypertensive retinopathy. On OCT, we can see that at the level of inner nuclear layer, there is a thinning and mild hyperreflectivity of the inner nuclear layer. And this is a picture of bilateral PAM in a patient who has a recent history of myocardial infarction and also a known case of hypertensive. The OCT angiography of the superficial capillary plexus remains preserved in this patient, whereas the deep capillary plexus is showing flow voids and capillary dropout areas, and there is a mild irregularity of the foveal vascular zone. What is PAM? Paracentral acute middle maculopathy is a OCT-based diagnosis characterized by band-like hyperreflectivity at the level of inner nuclear layer, and presumably secondary to ischemia, which is confined to the intermediate and deep capillary plexus, that evolves over week. This thinning and hyperreflectivity becomes eventually thin, or it's called the retinal ischemic paramacular lesions. Clinically, they usually present with acute paracentral scotomas, and the visual acuity more or less can be normal in most of these patients. These are most commonly middle to old age gentlemen or women. And in fundus, we can see it's usually normal. There can be subtle deep grayish or whitish lesion, which can be seen in some cases. They can be unilateral in some cases, like in the previous patient, can be bilateral. OCT generally shows a hyperreflective band, and in chronic cases, it can lead to inner nuclear layer thinning. And OCTA can show the intermediate and deep capillary plexus showing dropout areas. Now, this is a slide which is showing the pathogenesis here. PAM lesions sit at the level of the inner nuclear layer, which lives in the so-called watershed zone between the superficial and the deep retinal circulations. This zone is the most metabolically active and also the most vulnerable. The Croc cylinder model is used to explain why these watershed zones are most vulnerable for this. As we know, the superficial, intermediate, and deep capillary plexus are there. The superficial receives both serial and parallel perfusion, so it is relatively spared in cases of PAMM. The intermediate capillary plexus is the conduit which is feeding the deep capillary plexus, and DCP has no direct arterial input. It depends entirely on the ICP, and this makes it the most ischemia-prone layer. The anatomical asymmetry also, the smaller arterioles supplying the DCP are smaller than the venules which are draining it. The higher metabolic demand and the anatomical asimilarity, all these factors make it easily the most vulnerable area for PAM. And PAM is the earliest visible OCT marker in inner retinal layer ischemia. Worse insults usually progress along the cascade to BRVO, CRVO, CRAO type. So whenever we see PAM-like lesion, we usually think upstream. What is the driving hypoperfusion mechanism here? Multimodal imaging is one of the most important diagnostic features here. It's usually OCT and OCTA both. In OCT, in acute stages, we usually see band-like hyperreflectivity confined to the inner nuclear layer. It can usually extend to the IPL or the OPL sometimes. The outer retina usually remains preserved. In chronic stages, the inner nuclear layer thinning is there and it goes into the stage of atrophy. And persistent paracentral scotoma may remain in most of these patients. In OCTA, we can see that flow voids and capillary dropout areas are seen usually in the deep capillary plexus and can be variable involvement in ICP. The ICP is usually preserved in most of these patients. Acute OCTA can remain normal. The pruning usually develops in the subacute stages. There are 3 emphase OCT patterns which are described in PAMM. One is the arterioral pattern, where there is sectoral distribution. It's transient occlusion of the large retinal arterioles with rapid reperfusion. The globular pattern, where there is multiple ovoid hyperreflective patches, and fern-like varus is mostly seen in CRVO patients. Although OCT and OCTA are the most commonly described multiple imaging tools, there are other investigations like FFA, ICG, and other infrared reflectance, which can give a clue as to what is the other pathology which can be ruled out. Differentiating it from acute macular neuroretinopathy, AMN fundus appearance is usually a reddish brown petaloid wedge-shaped lesion, and apex is usually pointed towards the fovea. In PAMM, we have already seen that it's a grayish-white fern-like parafoveal lesion, and most of the cases the fundus can be normal as well. Other contrasting features between AMN and PAMM is that AMN is usually seen in young females, teens to mid-30s, but PAMM we usually see in older individuals with other lot of vascular and systemic comorbidities. The key retinal layer which is affected is usually outer retina, acute macular neuroretinopathy, and in PAMM it's usually the middle retina, the intranuclear layer. Fundus appearance we have discussed, and the primary underlying cause in case of AMN is usually oral contraceptive, like we have seen in young females, caffeine overstimulants, viral illness, shock or hormonal factors. In PMM, it is usually the common systemic factors are hypertension, diabetes, retinal vein occlusion, retinal arterial ischemia. When to suspect PAM? In a patient who's complaining of metamorphopsia, recent onset, and a relatively normal looking fundus, the history that we have to probe into include the vascular. The arterial tree would include, like we have seen in our patient, either I had a complete central retinal artery occlusion. It can also be seen in patients with incomplete or reperfused retinal artery occlusion. The same can be seen with venous occlusions as well. Other systemic important factors are diabetes, hypertension, sickle cell retinopathy. More common systemic vascular conditions include carotid artery stenosis, ischemic cardiomyopathy, recent cardiac arrests, and inflammatory markers like GCA, APLA, and ulcerative colitis. What is the point of diagnosis, evolution, and take-home pearls? Diagnosis, it's usually the symptom, which the patient usually tells acute paracentral scotoma or blurring of vision. The on-fast OCT is usually useful to identify the band-like hyperreflectivity, which is confined to the level of INL and OPL. OCT-A is clinching, where it shows flow voids in DCP and ICP, and superficial capillary plexus in PAMM is relatively preserved. The fundus can be unremarkable, so there is a very high index of suspicion which is needed to diagnose this particular OCT-driven entity. Evolution, the hyperreflective band eventually becomes thin, and that is when we usually call it as RIPL, retinal ischemic paramacular lesions. The scotoma may persist, so this is something that has to be counseled to the patient, and the burden correlates with the cardiovascular risk chain. Workup, a complete cardiovascular workup has to be done with ECG, carotid Doppler, and echocardiography. Blood investigations would include a complete diabetic profile, including lipid profile, and vasculitis and thrombophilia screening should be done in high-risk patients, like in the first patient where we had one eye complaining of, with one eye complete retinal artery occlusion and other eye with PAM, like in these patients. Thank you.
Dr. Subhashini, that's some very well documented cases and described very well. Dr. Manavi, would you like to throw some light on which suspicion, what are the clinical features and the patient symptoms which will lead to the general ophthalmologist that yes, this patient can have PAM or AMN, and then they should proceed for the OCT.
Since this is a vascular occlusive kind of a pathology, the symptom tends to be more intense. Like the scotoma would be more well defined for the patient, and their symptom or their complaint would be more stronger, so to say, than what would occur in other conditions like, say, CSR or something. And the retina would, essentially not really look very abnormal unless you look very critically on a slit lamp biomicroscopy. You will see that slight yellowish, dull appearance or on the macula, like we could see in the first fundus photograph that she showed. But the findings on clinical examination may again not be very, very prominent. So if the patient has a very prominent symptom of a central or a paracentral scotoma, then that should raise your suspicion. And the OCT and the hyperreflective band, which you see in the middle layers, is actually quite clinchy of the diagnosis in these cases. The unfortunate part of the pathology is that there is no actual treatment that we can offer. And as it resolves and the scotoma goes off, so again, here is another condition where you probably need to counsel the patients and hope that over time, the natural adaptive mechanisms of the brain can probably merge this scotoma away for the patient in some way. Yes, a systemic evaluation, a thorough evaluation for any thing which causes a vascular occlusion or a coagulopathy, a referral to probably a rheumatologist or cardiologist or some of the major cities and hospitals have these stroke clinics, can work. Again, in our experience, we have not really actually found anything happening much specifically in these patients, any specific systemic pathology other than maybe pre-existing diabetes or hypertension that they may have.
Correct. I think you are absolutely on point. The most important differentiating here between the scotoma is from the CSR is both of them are acute onset, but this is an absolute scotoma, that is a relative scotoma. And in CSR, usually it covers the area, but here it is a very specific, and the patient who is probably a Amsler chart, they will be able to locate that area of scotoma very precisely rather than CSR. And there should not be any retinal elevation or any presence of subretinal fluid. So that's how you can differentiate between a case of CSR and PMN AMN cases. Unlike the macular telangiectasia, MACTEL cases, they are more of a chronic patient. So they are gradually, there is a deteriorating, and here it is an acute onset of symptoms, which is very striking for the general ophthalmologist.
Yes.
Rupak, I want to make one comment.
Sure.
So whenever you suspect a drop in vision and on examination of retina, you don't see much of findings. So that's when you suspect, and you have a field defect, which is not correlating with your fundus findings. That's when you suspect things like this, a PAM or AMN. So one good feature, a good investigation to do in these cases, use a red-free image.
Correct.
Red-free image actually picks up these findings better. And in AMN, actually, you see a typical petaloid hypo pattern in a red-free image. Whereas in PAM, you don't see the hypo pattern, but you'll see that grayish pattern which is seen, which gets accentuated when you see a red-free image, which is not clearly seen even the regular color fundus photograph. And your field defects correlate well with whatever findings you are seeing on the fundus red-free image.
And there the area of scotoma and the lesion you can correlate, which is not clinical, and which you may not be able to clinically, locate pinpointly in that area.
Exactly.
Yeah, absolutely right. Absolutely. Thank you, Dr. Rajiv. We're running short of time, so we'll go to our last presenter, Dr. Shubham. Dr. Shubham Sinha Roy from Shankardeva Eye Hospital, Shankardeva Nethralaya of Guwahati. Here also a case of CSR mimicking cases. So the masquerading what we have seen initially of scleritis, so I've discussed with the leakage. Dr. Shubham, can you just start sharing your presentation, please?
Sure, sir.
And he will be presenting another case which is misdiagnosed as CSR, and then he has resolved in a different way. So Dr. Shubham, please.
Yes, sir. So first of all, thank you, Rupak sir and AYC for giving me this opportunity to participate in this webinar. So I'll be sharing a couple of cases where they were diagnosed as a CSR, and on detailed examination, you find the other way out. So coming to the first case, it was a 64-year-old gentleman who was known hypertensive for last 10 years. He presented with some diminution in right eye vision with that metamorphosis for last 1 year. And he had a 6-18 vision in the right eye. He is faking in both eyes. And he was diagnosed for last 1 year as a chronic CSC. And he was treated with multiple NSAIDs, epinephrine therapy, but with no relief. So what I got from the patient is the fundus photo in 2024. The patient had shown to us local ophthalmologist, and you can see a kind of RP alterations. You can see some demarcation line in the fovea, and this is the OCT I could see that time. And if you see in the left eye is completely normal, but the right you can see very shallow SRF lying at that macular area in the fovea with elongated shaggy photoreceptors. So based upon this finding, the patient was treated as a CSR and it was continued for a long time. He was also, I was able to take some fluorescent angiography done at his local center from the CD, and you can see the subsequent phases of angiography. He was suspected CSR, so done multiple times angiography. But you can see there is no point of any leakage. There's no leakage from the disc and no leakage from the pinpoint leaks or any CSR ink dot leaks. You can see some sort of hyperfluorescence at the later phases of the, angiography, but no definite leaks. So on examination, what we find here, on our examination, you can see this in the complete focus picture, and the whole photograph will show you in this arrow marks. You can see this demarcation line here. So if you see this demarcation line, you know that you're doing something not completely a CSR entity. And if you see inferior, you can see this bullous elevation of the retina, which tells us it is a long-standing inferior retinal detachment. And also there is some regression in the superior part and leaving a demarcation line. And this is what we have done, that OCT over here. And we have to look at the complete OCT. So we ran through the complete OCT. If you see this complete elevation of the retina, inferior arcade involving, and once you go up, the retina is completely attached. So this might have confused the doctor that what we are missing, because we are seeing only a single scan of the OCT and we are not seeing a complete thorough scan of the OCT because they're relying on that picture that was being given to me or given to the ophthalmologist. So this is how we have undergone the surgery for the patient. He undergone vitrectomy first with an oil emulsification. You can see the immediate posterior period refresh, laser to the multiple breaks he had inferiorly, and subsequently the patient has undergone phaco-IOL with a silicone removal, and then he has a nice compact fovea with a visual recovery up to 6/9. So this is how actually with a thorough examination we can really turn out things which is misdiagnosed in the CSR and it's coming out to the other way around. So coming to case 2, it was a 34-year-old gentleman who also was a known case of hypercholesteremia since last 10 years. He presented with diminution of vision and in the left eye for last 2 months. So he was symptomatic in the last 2 months because there was a metamorphosia, this blurry vision. He was a young patient of 6/18 vision in the left eye. Right eye was completely normal. And he was treated also as a acute SCSR followed by chronic phase. He was treated with the anti-VEGF injection elsewhere. He did some focal laser with no proper evident documentation of any angiography. And this is the photograph that I got from him, which is scanned image. And if you see in the right eye is completely normal. But if you see the left eye foci, you can see a very pocket of SRF. You can see some sister spaces in the at the foveal region, which will prompt the doctor to be finding as a CSR, because also the age is 34 years of age, and with no relief, the patient is coming to our OPD. But we have taken the picture of optos, both the right and the left. You can see the right eye pictures. You see multiple pigmented lattices in the superior quadrant. Also in the right eye, you can see the inferior quadrant, multiple lattices. You can see with the attached retina. But in the left eye, where he had the complaint of metamorphosis and diminution of vision, you can see multiple lattices in the superior quadrant. And also you can see a mark here just inferior to the disc showing a inferior SRF, which is extending up to the periphery. And you can see this pigmentation is showing the signs of demarcation with some break in the temporal area over here. So definitely we have diagnosed a case of long-standing case of inferior retinal detachment with multiple lattices in the both eyes. So the patient was advised for a scleral buccal surgery. And if you see this, again, the OCT video, the complete OCT video, you can see this line of demarcation even in the red-free reflectors picture, where you can see the demarcation between the two photographs where the inferior part is showing this hyporeflective state, hypoechoic state, will tell you that SRF over here. And if you run the videos, you can clearly see how it is OCT is going through, and you can show that complete demarcation of that detached retina and also the attached retina just above the fovea, which might have misdiagnosed. So this is after the scleral buccal surgery. You can see this bale buccal indentation over here in the left eye. You can see the cryo marks, which is getting scarred. You can see the lattice which is barraged. And you can see the shallow SRF still persisting because it was very fresh till after the buccal. The right eye, we undergone a laser barrage to the lattices, and also have done a laser barrage to the superior attached retinal lattice in the left eye. So just opposed to 1 year post-op, we have done a OCT, and you can see how the SRF is significantly reduced if you run the video OCT, and it is completely getting resolved with a very shallow amount of fluid left. Hopefully, it will resolve in the next coming 1 month. To the last case, case 3, where the 48-year-old gentleman presented with a diminution of vision in his right eye with a metamorphosis and shadow in his field of view for the last 1 month. He was having a 636 vision in the right eye. He was a myopic patient, which had done a cataract surgery, so he's pseudophakic. He was a high myopic patient. And he was diagnosed as acute CSR with the treated conservatively, but patient was not happy with the outcome. So he come to visit me. And I could get the scan picture. You can see the left eye showing a complete attached retina. You can see the myopic contour of the fovea. In the left eye, you can see there's a lot of noise, but you can see a very SRF, shallow SRF with the C-chord edema in the IRF, in the interretinal space, which might have confused with the CSR with the doctor. And you can see the optos image, although not very clear, but you can see one half, the retinal is completely detached with a shallow off retina with a myopic fundus. And if I got to the OCT video over here, you can see that how the retina is detached completely and the superior part is again getting attached. So this is definitely a case of rheumatogenic RD with the multiple breaks that we have operated the patient. And you can see the first post-operative period we've done a silicon field eye with a 360-degree barrage laser. And you can definitely see how the retina is nicely looking, the field defect is gone, and the OCT is showing completely formed fovea with the attached retina with a final BCVA gain of 6.9. So with these three cases, we like to conclude with the take-home message that definitely for a general ophthalmologist, you should not concentrate on only seeing the posterior pole with a 98D or 78D. So 360-degree fundus is very important once you're dealing with a subretinal fluid-like entity in the posterior pole, because it does not mandate you that it should be located in the posterior pole and missing RD in the periphery. So definitely have to rule out the retinal breaks in the periphery first, then to come out with the diagnosis of exudative SRF or a CSR-like entity. Also, you should look down the foveal scan. The majority mistake is that we'll advise OCT and the technician will give out a printout, and based on the printout, we'll diagnose this OCT scan as a CSR or something without going to the full reading of the scan and the video scan, which will tell you the many stories which is hidden within the OCT. And also try to avoid misdiagnosis so that you can avoid blind uses of anti-VEGF or a laser treatment and give a much better outcome to the patient, but rightly diagnosing the entity with an appropriate treatment. Thank you. And I acknowledge my fellow for helping me getting this photograph. Thank you.
Thank you, Dr. Shubham. I think he has, hit on the right nail. Dr. Hemant Murthy. So, sir, would you like to comment on these kind of cases, which is a very common scenario we do come across in our clinical practice as well?
No, I mean, that's the reason why I would encourage all students and young ophthalmologists. The first and most foremost point is to do a good dilated indirect ophthalmoscopy. I think that's mandatory before you do anything else. I think you all start treating the OCT, which is, I think, terrible because you don't do a good dilated fundus examination. I think just looking at the posterior pole and missing out such gross lesions which are easily detected on clinical examination. So I think the stress should be now not on investigations, more on clinical examinations, which I find that is somehow not being taken up very seriously by most people.
I absolutely agree with you, sir. We should be ophthalmologists, not the OCTologist. So that is probably one of the important take home which Dr. Hemant Murthy has told. And most of the cases, like I'm sure any of the expert panel also have come across, and could you just quickly share your experience, any of you?
I think it's very common, especially in our scenario, because many residents tend to see, cases directly, sometimes OCT. It's not that it's only happening somewhere in one corner. Every beginner tends to do that. You look at the macula, there is fluid, OCT, and that is CSR. So one very important clue on OCT is that there is no end to the serous detachment. So when you see that your OCT does not capture the end of the serous detachment, and I always tell my residents, like it's like taking a picture of one scan of CT scan and sending to our radiologist that he should interpret it. He would never interpret it, without taking into entirety. So similarly, when we see the OCT, we should never interpret a single scan unless and until we have made sure this is the most important scan to be interpreted. So we see all the scans and then we interpret the most important scan. That is very, very important thing to do. And of course, as Dr. Hemant sir highlighted very rightly, there is no investigation which can beat a good clinical examination. And I think in these scenarios, not even indirect ophthalmoscopy, a simple distant direct ophthalmoscopy will clinch the diagnosis.
So I also just wanted to share that we had one lady who was referred to us and had already received multiple anti-VEGF injections because there was fluid on the OCT, and she basically had a large HST temporally. And like Vinod very rightly mentioned, that the fluid was extending from the macula right till the periphery temporally, which had been apparently missed, and she was being treated on the lines of a CNVM. So I think this is a very important thing to be kept in mind. And the problem is that majority of the ophthalmologists who are not very well versed with the technique of indirect ophthalmoscopy. They'll end up doing a slit lamp biomicroscopy using a 90D or a 78D. And that is why their, clinical examination is confined only to the macular area. So when they see fluid on OCT, everything falls in place and they jump to some macular pathology only and start treating on those lines. So I think just to re-highlight what Dr. Hemant said, I think it's imperative that a thorough retinal examination is done before you come to the conclusion that you are dealing only with a macular pathology.
Yeah, absolutely. Absolutely. We are having 6 more minutes. So there are few requests from Dr. Santosh Onabhat initially. So Dr. Mohit, can you just, we'll take one point. I think 1 or 2 points has already been covered. What is the pathology of, I think we should discuss it for early, but let's in the concluding remarks also, what is the pathophysiology of micropsia, macropsia or metamorphopsia? So in short, if you can just tell.
Yeah, sure. Getting into the structural and the physiological part of it. So typically there has to be a mild or a exaggerated dissociation of the light that is passing through the retina. It can just be isolated photoreceptor kind of separation. It could be, ganglion cell separation. It could be bipolar cell separation. It could be all of these. So you could have pathologies at different levels. And if it's lesser, it'll be micropsia or macropsia, or it can be, a horizontal or a vertical metamorphopsia. You can, if it's only associated with the photoreceptors, then there will be photopsia, because that is what is actually causing firing slash misfiring of all of those things. So you can have pathologies affecting, the retina from on top, vitreomacular interface pathology. You can have some these 5 or 6 pathologies which can be outside the macula and affecting the macula, as was discussed in the last case, or different parts, the inner retina, the middle retina, so they can be affecting different cells like MACTEL. They could be affecting different vascular, conduits and channels within the retina. And I think one thing which is important to know is that these 3, although similar, and we tend to club them together, metamorphopsia can be seen in a variety of these conditions. I think micropsia and macropsia typically would be seen in outer retinal pathology. For that, it has to be a disruption slash, if not a total disruption, then a discontinuity of the easy interdigitation zone slash the photoreceptors. Because only with that can you get a variation in size, and the brain will actually interpret it that way. Whereas metamorphopsia, there can be, issues anywhere from, with the vitreoretinal interface all the way down to the photoreceptors.
Correct. So I think the third question was there a list of clinical condition in which a patient presents with these symptoms. I think Dr. Hemant Murthy has depicted very well, so that all the layers starting from the pre-retinal layer, that is a vitreoretinal interface, then the intraretinal phenomenon or the subretinal phenomenon, all 3 conditions can cause, our choroidal entity can cause like these kind of symptoms. And so majority of them, we have presented 6 presenters are there, so presented a good clinical scenario. Probably there are maybe 1 or 2 cases which we'll have a quick discussion, maybe 1 or 2 discussion, like epiretinal membrane or a vitreomacular traction can cause like similar kind of symptoms. Dr. Saurav Sinha, can you just tell what are the symptoms and what should be the point of referral if you notice the vitreoretinal adhesion or epiretinal membrane by a general ophthalmologist to a retinologist?
So I'll stick to immediately to the first one, the epiretinal membrane. So when you're looking at the macula with a 70D or 90D or whatever you're looking at, you see a thin glistening reflex over there or a grayish reflex over there. And if like, I think somebody said that if you look at the blood vessels over there, they're a little distorted and pulled towards the macula, then you're looking at a very relevant ERM. Any ERM that you can't see clinically, and I mean, it's very simple for the ophthalmologist, which you can't see clinically and which is shown on the OCT, is not such a big ERM. So to make it very simple, ask the patient to see the Human-Amsler chart. If they see a lot of distortion, a lot of haziness, a lot of curved lines, and you see a glistening reflex, and you see a distortion of the blood vessels over there, then possibly send to the VR surgeon to decide on the amount of vision loss or distortion and decide on surgery for that. That's an epiretinal membrane. Epiretinal membranes don't suddenly jump out and suddenly grow with their orbital detachments, so they can be followed up sometime depending on the age of the patient, the other eye, the occupation, the need for the patient. So ERMs, again, grazed reflex, vessel tortuosity, ERM, distortion on Amsler chart. I think an Amsler chart for all macular lesions that you're looking at will give you a very good idea of what the patient is saying and seeing, two different things. Patient may say a few things you cannot figure out, but if they ask me to show Amsler chart, even a dilated status gives a good information. One last point before I finish, and I'll go back to what Dr. Hemant Murthy said, and not today's presentations, but to request all the general ophthalmologists, any patient of flashes on floaters and floaters alone, an ultrasound is not the option. Dilated retinal evaluation is the option over here. Like we said, you miss the RD, you can miss a tear, you can miss it if you don't dilate a situation. Ultrasound will not show that.
Thank you, Dr. Sinha. And one more clinical scenario is GHPC or serpiginous choroiditis involving the choroid or involving the macular area also can present with these kind of symptoms. Dr. Manisha, can you just briefly highlight? We are just maybe just 1 or 2 minutes we have.
So I think that is a kind of a medical emergency if it is involving the macular area. And that is going to be the one when you are having choroiditis involving the macular area is going to be the one which is going to be the most symptomatic. Now, when I say it's a medical emergency, well, if you do not treat it on time, it spreads like a forest fire and can cause a very gross diminution of vision. How somebody needs to recognize it is when it is going to be active, you can have these linear patches of choroiditis which can be radiating out from the optic nerve head and involving the macular area. You can have certain patches of gray which are going to be mixed with the yellow patches, which are the partially healing patches of the choroiditis. So, of course, this could be accompanied with a hyperemic disc and other signs of inflammation in the eye. But majority of these patients are going to be actually presenting with a very gross diminution of vision. And as mentioned, it could also present with metamorphopsia. Now, in these patients, they have to be recognized very early on, and they have to be treated if it's involving or encroaching upon the foveal area. You have to treat these patients with intravenous methylprednisolone followed by oral steroids. Of course, we Indians are very prone to an underlying tubercular infection. So I think it's mandatory that you do a whole baseline investigations, rule out any infectious pathology, and then treat these patients with steroids.
This is absolutely fine. The fourth point, what Dr. Santosh Honavar has asked, what basic investigation that should be done. Sir, I think clinical examination is one of the most important parameter because where you can differentiate most of the things, along with OCT, which is freely available for the general ophthalmologist nowadays. That can give us a very clue key what they are dealing with, and if needed, always some retinologist help can always be seek for. And who should be triaged for the referral? Sir, the most important thing, I think, if you are dealing with which is very acute and inflammatory condition like macular GHPC or a CNVM condition, posterior scleritis cases, these are the cases which should be treated as fast as possible, followed by the chronic cases like CSR or pseudophakic CME and DME. And the few cases which you may not be able to do few of the things like macular telangiectasia or in AMN PAM cases where you can just need to observe. So it varies from the patient to patient, and definitely if any point of time if you have any doubt, probably you can take help from any of your retina colleague. We are done with the time. So, over to you, Dr. Santosh Honavar, sir. Are you here, sir?
No, I don't think he's there now.
Yeah, he's not there.
He's not there.
Yeah, he was there just few minutes back also. Okay, so let's conclude with this I think I would like to thank all the chairpersons and the expert panelists for their expert opinion about this. And this was exactly targeted to the general ophthalmologist. And the take-home message is, please believe on your clinical examination, and the basic investigation is OCT, by which you can differentiate a lot of the things of the macular pathologies. And if any point of time, you can take help from the retinologist as well. And my special thanks to all the presenters who has taken pain for presenting their cases, collecting their cases. And Santosh especially, and the IOS for arranging this fantastic webinar with this, most important topic. Thank you all.
I should compliment all the presenters. They were very nice presentations. I think I'm amazed by the presentation slides that they make. I think it's all very good nowadays. I think makes it a lot more interesting. Very nice. I think we had a good discussion. Thank you, everyone. I think the expert panel have really illuminated everyone. I suppose that's the most important thing. But I think the key, as Rupak had said, clinical examination should not, be lost in time to investigations.
Thank you, Rupak, for moderating it so well.
Yeah.
Thank you.
I think we will just put it at the end of this. Thank you all, and good night.